Welcome to Electrolytes 2, Potassium Disorders. This is part of PHRD 515 Renal Disorders course. I am Dr. Jeffrey Gonzalez. Today we'll explore potassium disorders, both hypo and hyperkalemia, common causes of each, clinical presentation, and signs and symptoms. In this class, we'll focus on the treatment of hypo and hyperkalemia. Please familiarize yourself with the learning objectives. These will be the basis of any exam or quiz questions. Disorders of Potassium Magnesium in DePero 12th edition is a great complement to this material. Before we dive deeper, let's review normal values of potassium. Normal serum potassium is 3.5 to 5 milliequivalents per liter. Remember, potassium is critical for neuromuscular and cardiac function, so even small changes can have a big consequence. For example, a potassium level of 3.2 milliequivalents might seem mild, but in a patient on digoxin, this can precipitate life-threatening arrhythmias. Potassium is the most abundant intracellular cation, as you can see here on the diagram. 97% of potassium is inside the cell. Remember, we cannot clinically evaluate intracellular potassium concentration. The concentration that we measure is of the intravascular compartment or serum, which is extracellular. Normal intracellular concentration is about 150 milliequivalents per liter, while extracellular is only 3.5 to 5 milliequivalents per liter. This steep gradient is essential for nerve conduction and muscle contraction. So signs and symptoms of potassium disorders generally involve the nerve or muscle. This is an easy way to remember common signs and symptoms of potassium disorders. How is potassium gradient maintained? Mainly through the sodium-potassium ATPase pump. This pump is found in all cells. The pump is responsible for maintaining an intracellular environment which is high in potassium and low in sodium. Increased sodium-potassium ATPase activity lowers the serum or extracellular potassium concentration and conversely decreases sodium-potassium ATPase activity. And conversely, decreased sodium-potassium ATPase activity raises in extracellular potassium. This pump moves potassium into the cell and sodium out. It is regulated by insulin, catecholamines, aldosterone, and acid base status. For example, after a meal, insulin drives potassium into cells, preventing dangerous spikes in serum potassium. Another clinical example, a patient with diabetic ketoacidosis may have high or normal serum potassium initially, but once insulin therapy starts, potassium shifts into the cell and levels can plummet, leading to hypokalemia if not supplemented. Remember, the kidney balances potassium intake with excretion so that potassium in generally equals potassium out. Potassium, like all electrolytes, is freely filtered at the glomerulus. This means that initially the concentration of potassium in the proximal tubule is equal to the concentration of potassium in the blood. However, 90% of that filtered potassium is reabsorbed first in the proximal tubule and then in the loop of Henle. The primary site for potassium regulation is the collecting duct, shown in the picture on the right. This is where potassium excretion in the urine occurs. There are several factors which affect potassium excretion. Some are mineralocorticoid activity, aka aldosterone, serum potassium, and the flow of sodium and water to the distal tubule. From a medication standpoint, the most important of these or aldosterone, and distal flow. In addition to aldosterone regulating our intravascular volume, it also regulates potassium. Increases in serum potassium stimulate aldosterone release, which works at the collecting duct of the kidney to promote potassium excretion. That's why medications that block aldosterone, both directly and indirectly, lead to a decrease in potassium excretion and hyperkalemia. Hypokalemia is defined as a serum potassium less than 3.5 milliequivalents per liter. Because potassium is necessary for muscle activity and rhythmic cardiac contraction, identifying and resolving hypokalemia is important. Hypokalemia does not imply total body depletion of potassium. Remember, most of the potassium is located inside the cell. We can only measure extracellular potassium in the serum. So there may be hypokalemia in the serum. However, intracellular potassium may be normal. An example could be a patient on high-dose furosemide for heart failure, prevents with muscle weakness and a potassium level of 2.8. This is a classic diuretic-induced hypokalemia. The three main causes of potassium are generally increased or decreased intake, increased or decreased redistribution of potassium, increased or decreased excretion of potassium. Decreased intake of potassium is a rare cause of hypokalemia because almost all diets are rich in potassium. If hypokalemia is caused by decreased intake, that usually means that the patient is overall malnourished. This can be seen in patients with eating disorders, alcohol use or abuse, or general lack of food. Hypokalemia is mostly due to the movement of potassium into the cell, loss of potassium through the GI tract, or through by the kidneys through excretion of potassium into the urine. We already discussed intracellular potassium shifts stimulated by insulin, catecholamines, beta-2 receptor agonists, and alkalemia. This tends to be a more minor and temporary cause of hypokalemia. Hypokalemia from GI loss is most commonly seen with massive diarrhea. And then kidney potassium loss is the most common reason for hypokalemia. First up are the diuretics. Loop and thiazide diuretics cause hypokalemia by increasing distal sodium and water flow to the collecting duct, thereby increasing the excretion of potassium and water. Vomiting leads to hypokalemia because it leads to an increase in bicarbonate delivery to the collecting duct. Bicarbonate binds to potassium in the collecting duct and increases potassium excretion. This table lists the most common medications that lead to hypokalemia, broken down into their general mechanism, either intracellular potassium shift, increased GI loss, or increased renal loss. You're responsible for knowing the ones listed in red. The catecholamines like epinephrine and albuterol can be common causes of intracellular potassium shifts, as can insulin, as previously discussed. Laxatives and cation exchange resins are common causes of GI loss of potassium. Diuretics are very common causes of renal loss of potassium. This chart shows the average daily potassium loss. In the stool, you can see that on average, you lose about 5 to 10 milliequivalents per liter. Sweat up to 20 milliequivalents per liter. And then urine is by far the most, up to 120 milliequivalents per liter in a normal adult. Hypokalemia disrupts electrical conduction in nerves and all types of muscle. This can lead to muscle weakness, paresthesias, and cardiac arrhythmias. Although not always true, symptoms tend to not occur until serum potassium falls below 2.5 milliequivalents per liter. Also, as with all electrolyte disorders, the more quickly the disorder develops, the more likely the person is to have symptoms. Cardiac and EKG effects are most worrisome complication of hypokalemia. Skeletal muscle weakness initially occurs in the larger muscles. You may see it in legs and arms. In severe cases, it can cause paralysis. The diaphragm is an extremely large muscle, so that can be affected initially. You may have depressed ventilation, respiratory ventilation, and in extreme cases, respiratory arrest from hypokalemia. You can also see loss of smooth muscle tone. This can cause constipation, nausea, vomiting, intestinal distension, or possibly paralytic ileus. Hypokalemia can cause many types of atrial and ventricular arrhythmias. Patients may complain of heart racing or slow heart rate, skipped heartbeats, and palpitations. The primary EKG changes are flattened T waves and ST segment depression. In severe cases, the T wave becomes inverted and the U wave appears, as shown in the pictures on the right. This is by far the most troublesome symptom and complication of hypokalemia. And if you see this in a patient, as far as any cardiac abnormalities in a patient with hypokalemia, you need to address it rather quickly. Now let's flip to the other side, hyperkalemia. Hyperkalemia is defined as a serum potassium greater than 5 milliequivalents per liter. In the absence of renal dysfunction, hyperkalemia is relatively uncommon due to the body's two-step defense of intracellular buffering and renal excretion. If the kidneys are working properly, they can generally compensate for any additional potassium load in the body. Hyperkalemia can be further classified as mild, moderate, or severe with the ranges listed there. Anything above 6.5 milliequivalents per liter is generally a critical value and needs to be addressed relatively soon. This hyperkalemia can occur in about 3 to 8% of hospitalized patients. Again, many of these patients are patients with renal impairment. Increase in total potassium is actually rare. And as discussed with hypokalemia, hyperkalemia can be due to increased intake, movement out of the cell, so redistribution of that intracellular potassium into the extracellular fluid, or, and this is the most common, a decreased renal excretion. Hyperkalemia results from those three general mechanisms: increased potassium intake from diet or medications, abnormal movement of potassium out of the cell, and impaired renal excretion. Acute hyperkalemia is often due to a combination of these three mechanisms. Chronic hyperkalemia is always due to impaired renal excretion. Hyperkalemia by increased intake is a rare cause due to the fact that kidneys are so good at increasing potassium excretion to remove the potassium load. Some medications, including over-the-counter supplements, penicillin G, and IV fluids given in the hospital, can contain amounts of potassium that may lead to hyperkalemia over time, most commonly in patients with impaired kidney function. Movement of potassium out of the cells can be triggered by all the factors previously discussed, including acidemia, lack of insulin, and medications such as beta blockers and digoxin. Digoxin directly blocks the sodium potassium ATPase pump in a dose-dependent manner and can cause hyperkalemia in overdose situations. Additionally, anything that causes cell death and cell lysis, will lead to hyperkalemia by releasing the intracellular contents into the extracellular fluid. This can be from rhabdomyolysis, massive trauma, hypothermia, or chemotherapy leading to tumor lysis syndrome. All of these causes just discussed lead to transient hyperkalemia, which may resolve when the kidneys excrete excess potassium. Only with impaired renal excretion will someone develop persistent hyperkalemia. This table lists some of the medications known to lead to hyperkalemia. As I mentioned, it's not a guarantee that taking one of these medications will lead to elevated serum potassium, and some are more likely than others. You're really looking for a combination of these medications plus other hyperkalemia risk factors. A great example would be a patient with diabetes, heart failure, and chronic kidney disease who is on several of these medications, such as carvedilol and lisinopril. It's our job as pharmacists to recognize the totality of these factors and have a strong monitoring plan in place, just in case hyperkalemia does develop. As with hypokalemia, muscle weakness can also occur with hyperkalemia. It tends to occur first in the legs and then moves up to the trunk, eventually the arms. However, hyperkalemia generally needs to be severe for this to occur. The most feared consequence of hyperkalemia is altered cardiac conduction, leading to deadly arrhythmias. This risk generally increases as plasma potassium increases, but EKG changes and arrhythmias can occur at any level of hyperkalemia. The first EKG change that develops is a peak T wave, as shown on the picture on the right, followed by increased PR interval, widened QRS complex, and eventually loss of that P wave. You can see the general signs of cardiac hyperkalemia may include bradycardia, peak T waves, like I mentioned, the QRS widening, and then the sine wave pattern, as you see on the bottom right, with a potassium level of 8 milliequivalents per liter. In summary, potassium disorders are common and potentially fatal.